Hi, welcome to your concept-based perioperative nursing lecture. Here are our learning objectives for this content. I've divided it up between perioperative or before the surgery and postoperative or after the surgery. So you hopefully will learn how to examine individual factors for potential threats to safety, especially for older adults. You'll be able to identify potential conditions or issues that need to be communicated to other team members on the surgical and postoperative teams. You will use effective communication when teaching patients and family about expectations during and after the surgical experience. You'll act as a patient advocate in regards to their rights and the informed consent and advance directives. And then lastly, on the pre-op side, you'll evaluate laboratory values and other diagnostics for changes that may affect the patient's response to drugs, anesthesia, and the surgery. For your learning outcomes in the postoperative phase, you will examine patient factors for potential threats to safety, especially the risk for respiratory complications, surgical site infections, and venous thromboembolism. You'll evaluate patient risk for complications of wound healing, prioritize nursing interventions for the patient recovering from surgery and anesthesia during that first 24 hours. You'll assess the patient's level of postoperative pain and evaluate his or her response to your coordinated pain management strategies and interventions. You'll evaluate surgical incisions and wounds for complications. And lastly, prioritize nursing management of patient teaching related to discharge orders. So hopefully by now, this being your last content for Wellness 1, you are thinking more in that conceptual mind frame. So I want you throughout this lecture, I tried to point out the different concepts we're discussing, but I want you to think about how the perioperative nursing really encompasses almost every single concept you've learned thus far in Wellness 1. So we'll be talking a good bit about oxygenation, perfusion and clotting, intracranial regulation, pain and comfort, glucose reg, fluid and electrolytes, infection, tissue integrity, thermoreg, elimination, mobility, safety, and that coping and stress adaptation that we talked about that very first week that you started nursing school. So the perioperative nursing care perioperative is the term that we use to describe the nursing care that's provided for patients before, during, and after surgery. So there are three phases of the perioperative patient care: preoperative, intraoperative, and postoperative. And we will be focusing on the pre and postoperative phases. Intraoperative or in the OR truly is a specialty and not something that you will need to learn about here. It's out of the scope of this content. So we're going to be focusing on that preoperative and postoperative phases. Okay, so I want to talk about the different surgical procedures and how we classify them. This slide talks about classification of the surgical procedures based on urgency. So how quickly do you have to have this done? Something that's described as elective is a pre-planned procedure that the patient chooses and we're able to get them on the schedule. Non-urgent procedure, it doesn't have to be done immediately. An example of that would be like getting your tonsils out, a tonsillectomy, getting ear tubes for ear infections, a hernia. All of those are elective surgeries. As opposed to an urgent surgery, and that has to be done within a reasonably short time frame in order to preserve health, but it's not an emergency. So if it's not done right now, the person will not die per se. So something like removal of the gallbladder, an amputation, removal of a malignant tumor. So those things all need to be done so that it improves their health, but it's not an emergency. As opposed to an emergency surgery has to be done right now. It has to be done immediately to preserve life, to preserve a body part, or to preserve function. Like an example of that would be if someone's rushed into the OR to stop a hemorrhage. Somebody's internally bleeding. They have to get into the OR to find out where they're hemorrhaging and to stop it. Repair of any type of trauma would be emergent. Perforated ulcer or intestinal obstruction. And then a tracheostomy where the patient is unable to breathe and they have to get in there in an emergency situation and perform this tracheostomy. Those are just examples of the different surgical procedures based on urgency. Surgical procedures can also be based on or categorized based on the degree of risk. So surgery can either be classified as minor or major based on how risky it is for the patient. So a minor surgery can be done sometimes in the doctor's office, an outpatient clinic, same-day outpatient surgical center. It carries a very low risk and low risk of complications afterwards. As opposed to a major surgery. Major surgery requires hospitalization, specialized care. There is a high degree of risk. It will involve major body organs or life-threatening situations and has a greater risk for postoperative complications. So this slide goes over the classifications of surgical procedures based on purpose. And the first one listed here is diagnostic. So a surgical procedure can be done to confirm a diagnosis. So a breast biopsy or an exploratory laparotomy is a good example. So something's going on in the patient's abdominal cavity, and we don't know what's causing the pain or what's causing the problem. They can go in and explore, just go in and look around. That's a diagnostic surgery. An ablative surgery is one where the surgeon goes in to remove something that's diseased, a diseased body part. I think the best example of this is an appendectomy. So a patient has an inflamed appendix. They go in and remove that diseased appendix. Amputation is another example of this. A colon resection is also in the category of ablative. Palliative surgery is surgery that's done to relieve or reduce the intensity of an illness. It is not curative, so you're not going in to cure something, to make it all better. So something like debridement of necrotic tissue, nerve root resection, colonostomy, all of those are considered palliative surgery. Reconstructive surgery is when a surgeon is restoring function to a traumatized or malfunctioning tissue, or it can be to improve self-concept. So like a breast reconstruction or a skin graft, a scar revision, plastic surgery, any of that is considered reconstructive. Internal fixation of a fracture is considered reconstructive, which I think is interesting. Transplantation is just what it sounds like. The organs are transplanted, and nowadays we can transplant just about anything from kidney to heart, joints, liver, cornea. And then the last category is constructive. So constructive surgery is when the surgeon is restoring function to a congenital anomaly. Congenital anomaly is something that the patient is born with. So constructive surgery would be something like a cleft lip repair, closure of an atrial septal defect, so heart surgery in the babies, or I've taken care of several patients that have had cleft lip repair, so that this type of surgery restores function in that example to the mouth and the oral cavity. So this slide just reviews the different types of anesthesia that you and your patients may come in contact with when undergoing a surgical procedure. General anesthesia is when the patients inhale the medication or they get it through their IV, and it is completely, it's systemic. So the entire body is central nervous system depression. The entire body, you don't have any, the patient doesn't have reflexes, they're completely relaxed. Moderate anesthesia involves IV of sedatives and analgesics that really kind of give you an amnesia, right? So that it can be reversed pretty quickly. Regional anesthesia does not cause sleepiness, but does result in pain relief and reflex loss. And then lastly, you have a local or topical anesthesia that targets a specific tissue or body area. So we often used a local or topical anesthesia in urgent care at Children's, where the kids needed to get stitches or something there on an extremity or whatever body part, and it just specifically targets the one area. So in the next couple slides, we're going to talk about informed consent, advance directive, patients' rights. One of our learning objectives is that you as the nurse are the advocate for the patient in regards to these documents. So an informed consent is a legal document that is presented to the patient by the surgeon or physician, in that the patient is voluntarily agreeing to undergo the procedure that's being presented to them. It has to be written. It has to be designated for the procedure that's about to be performed, and it has to be signed by a patient or a person legally responsible for the patient. One of the things you need to know about, though, is that if it is in an emergency, like we talked about that emergency surgery where a patient has been in a trauma and they're bleeding extensively and they need to get in and stop the hemorrhaging, stop the bleed, but there's no one around to sign the consent, the surgery is done with implied consent. We don't hold up an emergency surgery because we don't have a consent, is what I'm trying to get to, okay? So as a nurse, your responsibility is to make sure that your patient has the information that they need. You do not provide that information. The surgeon or person completing the procedure is the one that must present to the patient the information that includes what is the procedure they're going to be doing, what are the risks and benefits, what are other options if you don't do this surgery. The surgeon or physician who is obtaining that consent is the one responsible for clarifying anything, making sure that the patient comprehends, making sure that they are competent to make the decision, and that they're giving this consent voluntarily without any type of manipulation or coercion, okay? If the patient doesn't speak English, we must get a medical translator to make sure that the consent is in the language that is their native language. You will be responsible for documenting that the consent process has taken place. So you look at the consent form and make sure that the signature on the form is the patient's signature. Do not confuse that with the actual explanation that's given to the patient. So and we'll go over this preoperative checklist, you will be documenting that, yes, the patient has signed a consent form. You will be responsible for assessing whether the patient understands what they're signing, whether the patient has done it voluntarily. And if there are any issues, you are responsible for reporting any problems or any uncertainty to the person that's going to be doing the procedure. Things that can cause issues when obtaining a consent form would be language barriers that we just talked about, any type of cognition or confusion. If the patient doesn't understand, then that consent, that's an issue with the consent, right? If they're on pain medication, the surgeon has to get the consent form when the patient is able to comprehend the information that's being relayed to them. So an advance directive is a legal document that allows the patient to discuss wishes with their family members and in advance before the surgery, okay? So it's generally the policy, or it's generally the, pretty much institutional policy that there is an automatic cancellation of the DNR status when somebody goes into surgery. Okay, so let me explain that. If somebody has a DNR, do not resuscitate or allow natural death order, unless discussed otherwise, the DNR does not remain intact while in surgery. So the people in the OR will do what they need to do to get that patient through surgery and back to the recovery room or the PACU. Okay. Typically, it's an institutional policy of automatic cancellation of the DNR status in cases where surgery is carried out. However, when that automatically cancels, the patient is not participating in that decision making. So there's something called a required consideration discussion. And I'm going to give you a real live example of this. My best friend from nursing school, and I've asked her if I could share this, and she said I could. But her mother, 93 years old, had a aortic aneurysm, dissecting aortic aneurysm, has been a DNR and on hospice for several months now. Just fell and broke her hip. Okay? Because they were doing the surgery for palliative reasons, they were going to go in and fix her hip to make the pain better. My friend Anita had to get this discussion rolling with the anesthesiologist, with the surgeon, on what do we want you to do while my mother is in the OR. So we are not suspending our DNR. We want to continue to keep her a DNR, but this is what you're allowed to do. So if she needs albumin, you can give her a little albumin. If her blood pressure starts to go hypotensive, you can give her a little bit of fluid to get her up. It's specific points in the OR that the anesthesia and the surgeon is allowed to do, and then once they come back out of the OR, then the DNR is back in force, if you will. But unless you have those discussions, if someone is a DNR and they go into surgery, that DNR is automatically canceled when they're on the OR table. So it's real important to have these discussions if you have a patient that's DNR and going into a surgery. So that's not something that, and it wouldn't be just you by yourself, but I wanted you to be aware of this required consideration and the idea about the DNR advance directive and you advocating for your patient in this situation. Now we're going to start talking about some risk factors that increase a patient's risk for postoperative complications. So with any surgical procedure, there are risks. However, there are circumstances or potential conditions or issues that you as a nurse will need to communicate to other team members of the surgical and postoperative teams that allow them to be more aware of the increased postoperative complication risk, okay? And one of them is a patient's medical history. So if one of your patients is about to go into the OR and you're in the holding room in pre-op and you're working them up, and your patient has cardiovascular disease, and I labeled out some examples here. If they have hemophilia, thrombocytopenia, anything that impacts their ability to clot, if they have had a myocardial infarction, if they have a dysrhythmia, any of these cardiovascular diseases will increase the risk of anesthesia complications. They could bleed out, so if they have hemophilia or have an issue with clotting, right? They could have hemorrhage after surgery. They could go into hypovolemic shock, hypotension. They could have overhydration with IV fluids if they have cardiac issues. If somebody is on your pre-op list and they're about to go into surgery and they have respiratory disorders, things such as COPD and emphysema, asthma, bronchitis, they have an infection, they have pneumonia. All of those respiratory disorders increase the risk that your patient could potentially have respiratory issues from anesthesia. They might have respiratory depression. They might be at greater risk for postoperative pneumonia or postoperative atelectasis because of these respiratory disorders. Because of COPD, emphysema, they might be at more risk for an acid-base imbalance, right? All of that we've talked about in previous discussions. If your patient has a history of kidney and liver disease, that could really impact their response to the anesthesia. That could affect how they metabolize the different drugs or anesthesia that's being used, right? Endocrine diseases, especially diabetes, increases the patient risk for slow wound healing, for postoperative cardiovascular complications, possibly acidosis or hypoglycemia. So if a patient has any of this in their medical history, it's your responsibility to make sure that the team is aware of this history because of the increased risk of complications. Another piece or risk factor that would increase post-op complications and things that need to be communicated to the anesthesiologist, to the surgical team, are surgical histories, right? Has your patient already had heart or lung surgery that makes them more vulnerable to the anesthesia, makes them more susceptible to things such as deep vein thrombosis or the forming of a clot? Do they have a latex allergy? Have they ever had malignant hyperthermia? So malignant hyperthermia is an extreme complication that causes very high fevers related to anesthesia. And typically there's a familial family there, it can be inherited. So that's something you want to ask when you're in the pre-op checklist. Have you or anyone in your family had issues with high fevers with surgery? And not just the typical fever that can happen after a surgery, but an extreme complication in the OR. Medication history, again, is your patient on any type of anticoagulant that's going to impact their ability to clot during surgery? Are they on diuretics, tranquilizers? Does your patient have excessive alcohol, drug use, nicotine use? All of this information is going to be very important to communicate because it increases the risk for drug-related complications, or the nicotine can I don't know if we talked really a lot about patients that are smokers, but they're at higher risk for respiratory complications after surgery because smokers already have an increased mucus secretion, and that ciliary action is decreased in their tracheobronchial tree, right? So when somebody is in surgery, patients have pulmonary secretions, right? They retain that pulmonary secretion. So if somebody is a smoker and they already have that increased mucus, they're at higher risk of having pulmonary secretion-related issues, right? Risk factors such as ADLs, activities of daily living. Is your patient more sedentary, or they have good exercise, rest, and sleep habits? If they have if they have that going for them, then they're going to be at less risk. If they are malnourished or very sedentary, they would be at higher risk. And then lastly, the coping patterns and support systems. So as the nurse that looks at the entire body, right, you will be needing to assess the patient's psychological and spiritual adaptive coping patterns, so that you can make sure that the surgeons and the team is communicating with the patient about their fears and their concerns about the surgery. That first bullet point when I presented the risk factor was age, right? So the older adult over the age of 65 will need to have special consideration when planning the care of the older patient preoperatively. I've listed out here the concepts that need to be assessed and looked at in the older adult population, and I've delved even deeper into those areas in the next couple slides. On all of these slides coming up here, I'm not going to read all the nursing strategies, but I want you to be familiar with what we would do as nurses so that we can address these age-related changes. So in the older adult, they have increased vascular rigidity, decreased peripheral circulation, and decreased cardiac output and stroke volume. So that puts them at higher risk, like we just talked about, for complications. These nursing strategies listed here hopefully will combat or help decrease those risks for the older adult in a cardiovascular capacity. The older adult has reduced vital capacity for their lung space. They have diminished cough reflex, decreased oxygenation in the blood, decreased chest expansion. Their intercostal muscles and diaphragm strength is diminished or lessened. They're not as strong, right? So they can have issues in the respiratory pulmonary area postoperatively. So we will need to do all of these interventions, such as auscultating the lungs, assessing their breathing, teaching them to cough and deep breathe, teaching them the incentive spirometer. All of that will be important to increase or decrease their risk of complications. Intracranial regulation concept. With an older adult, they have a decreased coordination or reaction time. Their short-term memory is reduced, sensory deficit issues, and decreased thermoregulation ability, right? So they are unable to conserve their body heat. They might have issues with being disoriented after surgery. The older adult has decreased renal blood flow and reduced bladder capacity. Their renal function is not as sufficient or efficient as the younger individuals. So it's very important to monitor their fluid and electrolyte status, to record their INOs. Older adults also have prolonged gastric emptying time. They have decreased hepatic blood flow and enzyme function and increased gastric pH. So it's very important to monitor their nutritional status and watch for prolonged effects of medications. And lastly, in the older adult risk factor or individual factors that can potentially threaten the safety of older adults. They have decreased subcutaneous fat, decreased skin moisture and elasticity, and decreased vascularity. So it'll be really important to make sure that they have good range of motion, reposition as needed, monitor their fluid status, and protect their skin integrity, protect those areas of pressure. All of these older adult considerations should be just a review for you throughout the semester, but I wanted to make sure I pointed out the changes, physiologic changes and subsequent nursing strategies. So our last learning objective in our preoperative phase is that you are able to evaluate laboratory values for changes that may affect the patient's response to drugs, anesthesia, and surgery. When a person goes into surgery, we want them to be at their optimal health, if at all possible. So I've listed down here the different concepts. I want you to correlate these concepts to these laboratory and diagnostic tests that we're going to want to make sure are done on our patients preoperatively before they go into the OR. So some of the most common things we get done on patients before they go to surgery would be a UA, a urinalysis. So we're checking to see if they have a UTI infection. We want to make sure that they're hydrated. So we look at their specific gravity. That has to do with fluid and electrolytes, right? We want to look at glucose in their urine because if their glucose is high, whether they have diabetes or not, it could increased glucose will increase the risk for infection, right? So we also type and screen all of our patients. So in the event that our patients need a blood product, we're ready for that. So the blood bank has their blood type. They are available. The blood is available at the blood bank, again, depending on what type of procedure that we have that the patient is undergoing. Our patients we want to make sure laboratory-wise they get a complete blood count. So that CBC, remember, includes looking at the white blood cell, looking at the red blood cell. So for the white blood cell, we're looking at infection. For the red blood cell, we're looking at anemia. The CBC also tells us about platelets. So we're looking at clotting. Looking at other things in a CBC to determine whether there's anything we need to correct before we go into surgery. Again, we want them to be at their optimal health before they go into surgery prior to getting that anesthesia. So we're going to look at clotting studies. We want to see how long, if they can clot, and how long it takes them to clot. Electrolyte levels, so with that we're looking at potassium and sodium, chloride, creatinine, blood urea nitrogen, otherwise known as BUN. We want all of those to be within normal limits, right? Because if they're not within normal limits, then we'll want to correct them. It's really, really important that we know what these levels are going in. For example, if we have a patient that has had these lab work a week before surgery and their potassium, let's say their potassium was 4 before surgery, right? And then we bring them into the OR to the holding and they get another electrolytes and their potassium is down to like 3.3, right? We'll want to make sure that we notify the anesthesiologist and that they're aware of what this level is, right? Because potassium, if it's too high or too low, can cause cardiac issues. So it's really important that if it's low going in, we don't want them to drop lower in surgery because it can drop afterwards. So we want to make sure we're on top of that. Creatinine and BUN, again, tells us from a renal standpoint whether they need extra fluid going in. So the patients have a tendency, or they can come into surgery being dehydrated to begin with, right? So we want to make sure that we assess that and we correct it before they get into surgery. Obviously, serum pregnancy on females only. No need to get that on the male population. And this is really important because some people can get into surgery and not realize that, or get into pre-op and not realize that they're pregnant. So everybody of childbearing age will get this pregnancy test because there are a lot of things we don't want to do in that first trimester of pregnancy, and anesthesia to a pregnant females can cause fetal demise. So we would want, that's a laboratory test we want to make sure we take into consideration. Diagnostics, depending on the age and other factors, we would want to get a chest x-ray before they get into the OR to determine what's going on with their lungs, whether they have any edema or hypertrophy of the heart. The EKG is going to give us an electrical picture of the heart, the electrical conductivity of the heart, really show us what the heart health is. Vital signs, of course, we get that on everybody. We want to watch their blood pressure. Are they hypotensive? Are they hypertensive going in? Are they tachycardic? Going to auscultate their breath sounds. Do their lungs sound good? Do we have crackles? If we have crackles going in, that might indicate overload, right? How are their breathing patterns? Are they working to breathe? And then, of course, a pain scale on our patient. And again, look at our concepts and try to kind of correlate or match them up to all those laboratory and diagnostics that we just discussed. Now I've listed some things that we also will potentially be doing for our patients. A bowel prep is typically done on anyone that's going to have any type of abdominal surgery. And what that is getting the contents of the bowel evacuated. So we want to clean them out. We want to make sure that there's no stool in the intestines, in the bowels. They go through a regiment, if you will, to make sure that they get all of the stool out before we go into surgery. Because if a surgeon cuts on the abdomen and we have any type of bowel feces that goes into the abdominal cavity, which is sterile, that can cause a life-threatening situation. They can become septic, and it is a very bad situation. So a bowel prep is not to be taken lightly. If it is an abdominal surgery, the patient needs to go in until they're clear, okay, until it's adequate. They're clear coming out, which means no brown, no stools. Everything should be coming out clear. Oftentimes we'll give an enema in the pre-op area just to make sure that it's all been evacuated. Skin preps, I had this done myself when I had my orthopedic surgery. I had back surgery, and skin preps are done a lot with orthopedic cases. We use chlorhexidine, which is the same cleaning agent that you will use when you clean CVL dressing changes. It gets all the microbials off the skin. Because in orthopedic surgery, you're cutting into the bone, and it is extremely bad to get an infection into the bone. It's called osteomyelitis. So we'll do some skin preps for our patients. NPO after midnight, obviously, is nothing by mouth after midnight, because we don't want them to have anything in their intestines, in their which once they're under anesthesia, we don't want them to aspirate anything. This skip protocol is something I'm just putting in here to make you aware of. The glucose regulation is included in this skip protocol, and so let me hit on that first. There is a huge link between glucose and infection. The link is very, very tight. So on post-surgical patients, we want to keep their glucose in control, because the more glucose they have in their system, it can fuel infection. So we want to be very cognizant and regulating that glucose and have a real tight control on them. You know, patients can come in hypoglycemic with a low glucose, or they can come in hyperglycemic, right? So with patients that are NPO, they haven't eaten, and or they've gotten these bowel preps, their glucose might be low when they come into pre-op. Well, we can't just give them orange juice to bump up their sugar, right, because they're NPO. So we typically will give them D50, a little bit of glucose in their IV to get that blood glucose. Or if they're hyperglycemic when they come in, then we'll give them insulin or give them something to bring that down so that we're in that regulated glucose normal range. And that is to prevent increased chance of infection. Okay, lastly, the SCIP protocol. So the SCIP protocol are initiatives that are in place. The Joint Commission helped, there was a big quality improvement project that was created, but there are maybe 11 protocols that all are in place to minimize or decrease the risk of postoperative complications. Things such as Making sure antibiotics are ordered and received 1 hour prior to surgical incision. So you're in the pre-op holding area, your patient's going to be going to surgery, they will be given an antibiotic prophylactically an hour before they go into surgery. Then they will be given an antibiotic 24 hours after surgery, and then that antibiotic needs to be discontinued. Things such as hair removal from the patient. Instead of shaving them with a razor, we'd use clippers, and that would be avoiding nicking the skin so that we minimize any type of portal for those microbials or any infection to get in, right? Another skip protocol that is revolving around or involving infection potential would be removing the urinary catheter or Foley catheter within 24 hours of the surgery to prevent those infections. Control the temperature of the patient in that controlled environment to make sure that the patient's core temperature remains consistent. Yeah, that's where I want to go with that. So I want to kind of summarize what we've talked about already in this slide with preoperative education. One of the biggest things we need to make sure we're doing is to make sure that there's a signed consent on the chart. Surgeon's responsible to obtain it before any sedation is given, before any surgery is performed. You as the nurse are responsible for making sure that it is signed. You can witness this consent, but it is the surgeon's responsibility to get it. It is, I always will say to the patient, I'll bring the consent over to him and I'll say, this is the consent form that Dr. So-and-so has gone over with you. Is this your signature? Yes, you're confirming that the signature, and I can witness that signature. But what questions do you have for the surgeon before he or she leaves so that we can make sure that you're aware of what's going on? Okay. CDB is cough, deep breathe, incentive spirometry. These are all very important to educate your patient on prior to surgery so that they know post-operatively we're going to be asking you to cough, deep breathe, blow into the incentive spirometry to prevent any type of respiratory complications. Mobility-wise, we've got to make sure we're getting you up and ambulating. Early ambulation is going to prevent not only respiratory complications, but prevent blood clot possibilities, right? So early ambulation, pain management. We want to make sure that the patient is aware that they need to be asking for their pain management or their pain medication. We get them medicated prior to getting them up that first time so that we can manage that pain so that they will do what we want them to do, right? I always say to the patients after surgery, the first time you get up is the hardest. This is going to hurt, because it is. Don't lie to them. I'm going to medicate you. I'm going to medicate you 30 minutes before you get up. Now let's get up. Now let's cough. Let's deep breathe. Now let's walk around. It's hard work, but you have to put that hard work in so that you can prevent postoperative complications and get home. VTE prevention. VTE stands for venous thromboembolism prevention. So you're preventing a blood clot. I'm almost positive all of you have on the floors already given anticoagulants, Lovenox, heparin, prophylactically, postoperatively, or if somebody is immobile in the bed to prevent a blood clot. You also will have you will encourage the patients to pump their feet, get their leg exercises so that you're contracting those muscles to hopefully prevent a blood clot, to get the SEDs, the sequential devices on to prevent the blood clots. Additional prep immediately preceding the operating room, preoperative medications. Typically, if somebody's on a beta blocker or a hypertensive med, they will take that before they go in because we don't want their blood pressure to go sky high once they get cut on. You will have the patient remove their clothes, get in a gown, make sure any piercings are removed, dentures, glasses, contacts, all taken out, put in a bag and given to the family. And don't forget about the family. Make sure the family member is aware of what's going on, how you're going to communicate with them while they're in the OR, while, when they get back out, what they can expect. Again, on the bottom of this slide, I have listed the concepts, and I want you to think about which concept goes with which of these education pieces, right? Oxygenation, I hope you all know, goes with the cough, deep breathe, and incentive spirometry. Perfusion and clotting, I hope you all know, goes with this VTE prevention. So think about this conceptually so it'll kind of stick in your brain. This is one of my favorite slides. Y'all know I'm a very visual person, so here you will have a pre-op checklist prior to sending the patient into surgery. So preoperative education completed, check. Informed consent signed, checked. The patient has been NPO or gotten a bowel prep. They've had a skin prep. You've documented that their valuables are with their family. They voided prior to transfer. Not only is that important, but they need to void prior to giving them pain medication. Once you've given them pain medication, they are in their bed with their side rails up, bed lowest position. They do not get up to use the restroom because they've been sedated. Pre-op medication, side rails up. After pre-op med, bed in lowest position, hospital gown. They have their allergy and ID bracelets on. All those items have been removed that we just discussed. Vital signs, but right before they're transferring, typically I'll fill out the pre-op checklist, and as soon as the transport comes, I'll get another set of vitals so they're fresh and right before the patient leaves to go to the OR. And then on the chart, they must have a history and physical by the physician and their medications. And all high alert meds noted, and that the pre-op lab work is on the chart, and the surgeon has been notified of any of those abnormal values that we just talked about. Okay, these are the areas, the NCLEX key points related to preoperative nursing. So the safe and effective care, a lot of questions revolving around does the patient have an advance directive? As a nurse, you ask the patient to explain what's being done and why. If what they say is inconsistent with documentation, it is our responsibility to notify the physician and have the physician discuss with them. You always want to identify your patient with 2 identifiers. Make sure that they have their armband on, any allergy band on, if applicable. That the patient is not asked to sign a consent or any other legal document after a preoperative drug has been given. Once you have given medication, they can no longer sign the document. Once they've gotten that pre-op medication, their side rails are up, the bed's in lowest position. We just talked about if they have to go to the bathroom, you get them a bedpan or something on the bed. You never let them up after they've been medicated, because sure enough, they get up, they fall, then you have a safety issue. You communicate with your surgeon and anesthesia any condition or change in lab values, like I just talked about with the potassium. That was 4 pre-op a week ago, and now it's 3.4. We notify the doc so that they know going in, this potassium is low, we want to address it before they go into the surgery. Health promotion and maintenance, you want to talk to the patient about that, any kind of diet restrictions or limitations after surgery, any type of splinting. So if they've had abdominal pain, we'll want to teach them how to put a pillow on their abdomen and splint the incisions so that they can do their CDB, their coughing, deep breathing, and incentive spirometry. We teach them those interventions of pumping the feet and range of motion.
Psychosocial integrity, you want to make sure that what you're teaching them and how you teach them is adequate for their learning, right? So if they're not understanding, you need to slow down. You need to encourage the patient to tell you how they're feeling and address that stuff. Communicate with the physician and anesthesia any concerns or worries that the patient has. And then lastly, the physiologic integrity. I didn't talk about this yet, but if a patient was going in for surgery on anything that there are two of, 2 arms, 2 legs, 2 breasts, so there's a left one, there's a right one. Very important that the organ or the extremity, whatever is being operated on, is marked appropriately. So you have a patient that is going to have a right mastectomy, going to have a right breast removed. So then you go in and you make an X on the left breast and a check, or this is the correct arm, so that you identify that extremity so that there's no errors on wrong site, wrong extremity. Okay. Again, physiologic integrity, make sure that all dentures, contacts, piercings, everything's off and removed before the patient goes to the OR. Whew. Now let's look at the last phase of the perioperative process, the postoperative nursing phase. So now let's look at our concepts postoperatively. These should look very familiar. Some of the same concepts we looked at in the preoperative stage. So oxygenation, perfusion, intracranial regulation, thermal regulation, tissue integrity, pain and comfort, and elimination. So all those potential risks in the preoperative phase can now become actual issues postoperatively. So understanding what your patient's risk factors are prior to, and depending on what type of surgery, for example, if they're having surgery on the lungs or the heart, they're going to have more issues there than if they're having foot surgery per se. Intracranial regulation issues, especially with older adults, that change in environment. It's a reality here. They're changing mentation. Anesthesia is not a normal thing for older adults to go through, so it's a big change for them. And you also have to realize that they don't metabolize the medication at the same rate as a younger person would. Also the inflammatory response. So after surgery, the body's been through a lot. There's the general inflammatory response, a lot of fluids being sent. The body is reacting because something's foreign, right? So it can cause them to have a little bit of a temperature. Typically, we don't do anything for anything lower than, until it gets to like 100.5 or higher. And oftentimes moving around, coughing and deep breathing can help with that, the secretions, and therefore help bring that temperature down. Tissue integrity, you've got an incision there. Pain and comfort, you've got an incision there. They're going to be in pain. For elimination, don't forget that anesthesia puts the body to sleep altogether. So a person can wake up from the anesthesia, but it takes longer oftentimes for the bowels to wake up. So they're at risk for paralytic ileus. So we want to make sure that the patient gets up and ambulates, because that's going to stimulate the GI tract and hopefully wake that up, and we don't want complications in that elimination concept. Okay, so now we're going to do a focused assessment. We've got our patient back from surgery. They are out of the recovery unit, otherwise known as the post-anesthesia care unit, the PACU, and they're on our post-surgical floor, and they'll be with us 2 to 3 days. Here are things that every post-surgical nurse assesses. This is like a checklist, mental checklist that I go through, and what I want you to assess and think about when you're caring for somebody post-operatively. These are some questions that I ask myself as I'm assessing them. Okay, so in the oxygenation concept, do they have an airway? Is it a patent airway? Is their neck in alignment? How's their breathing? What's the quality, pattern, respiratory rate? What's the depth of those respirations? Are they on oxygen? If so, how much? What's their pulse ox or their oxygen saturation number? Are they above 94, 92? You know, that it's going to address that oxygenation status of the patient. How are their lungs? If I get them to cough and deep breathe, are their lungs the same or did it clear up at all? In the perfusion category there, you're going to be checking their vital signs, of course. Do they have adequate blood flow? What's their heart rate? Let's look at the fluids they have hanging. How much solution has infused thus far? Do they have any additives like potassium in their IV? How much fluid did they get in the OR and the PACU? How much fluid are they getting here on the floor with me? What's their deficit? Are we making up that fluid volume? Are we balancing out? Looking at intracranial regulation, their mental status. Is the person awake? Are they able to be aroused? Are they oriented? Can they tell you where they are, who the president is? Are they aware of their surroundings? Or does the patient respond to verbal stimuli? So when you walk in the room and you say, hey, Mr. Holmes, will they respond to you when you verbally talk to them? Or do you have to lay hands on them and kind of touch their shoulder and elicit some type of response? How asleep are they? How much anesthesia or pain meds are still on board? Tissue integrity. You're going to have to assess the surgical incision site, or if it's dressed, if there's a dressing on it, is there any drainage on that dressing? If there's any shadowing, which is you look at a dressing and instead of being completely dry and intact, there's like a little shadowing so you can see that there's some blood that's seeping into the dressing. If there is, you take a pen or a marker and you outline where that shadowing is occurring and date it and time it so that you can monitor. It gives you a visual clue if the bleeding is continuing. So if it extends beyond those borders, the drainage is continuing to happen, right? So you look So are there any drains? If there are drains, are they draining? Is it kinked? You want to look at the drainage in not only the dressing, but also in these drains, JP drain, Jackson Pratt, different types of drains. But you're looking to see what the color of that drainage is. So is it serous, which is light yellow? Is it serosanguinous, which is a mixture of that light yellow and blood? Or is it sanguinous? Sanguinous, remember, is mostly bloody with very little serous. And that sanguinous might give you an indication that it's more of an active blood or active oozing, and that could be potentially a reason to call the physician. Pain and comfort. How is your patient describing his or her pain? Is it being relieved by the pain medication and therefore letting them do their interventions? Tubes, lines, drains. We already talked about the drain coming out of the incision, the JP drain, and looking at the drainage. What about does your patient have an NG or a nasogastric tube? If so, is it hooked up to suction? What's the drainage that's coming out of there? What's the consistency? Does your patient have a Foley, a urinary catheter? If so, what's the color, the clarity, the volume of the urine output? Those are all things, in your focused assessment in a post-op patient that you should go down the line, and that should be your mental checklist as you're assessing your post-op patient. So immediately post-op, your patients will be on more frequent vital signs. As you can imagine, they're in a more immediate post-op phase, and you need to be more aggressive and monitoring them closely. So they get to the floor. This does not pertain in ICU. This is a post-surgical floor. As soon as the PACU nurse brings your patient up, you get that initial vital sign upon arriving to the floor. And 30 minutes later, you'll get your second. So post-operative vital sign protocols are every 30 minutes times 2, every 1 hour times 2, and then if they are stable, every 4 hours thereafter. So you get them back from the PACU, you get your initial set of vital signs, and then 30 minutes later, you get your second. and then you go to 1 hour times 2 and then Q4. But make sure that you pay attention that if your patient is not stable, you don't continue down that line. So if you get them and at every 30 minutes times 2, they're not stable, well, you're going to do them more frequently, and you're going to contact the charge nurse, the physician, hey, there's something going on, this is trending the wrong way. So you progress through those vital signs as they are more stable, as they become stable. So here's a list of complications that can occur based on the concept that we've already discussed. We talked about these as potential risks for complications in the preoperative teaching and assessment discussions. And now these are actual complications that the patient has. So it's no more risk for, but they do have atelectasis. They do have pneumonia. And the reason we do all that pre-op teaching, that cough, deep breathe, ambulate, prophylactic medication, antibiotics, prophylactic blood thinners to prevent the blood clots, checking the incision, looking at the skin, making sure there are no ulcers, GI, making sure that they're walking and moving around, doing everything we can to stimulate the gut. One thing that we didn't talk about, which we probably should have, is GI ulcers and bleeding. All patients postoperatively will be on some kind of H2 blocker like famotidine or PPI like Protonix. And those medications decrease the production of hydrochloric acid in the stomach. And the reason we have them on these medications, regardless of the type of surgery, is because surgery causes stress on the body, okay? Stress increases the production of that hydrochloric acid. Stress also increases the production of cortisol, which increases glucose. So not only are we concerned about the increasing hydrochloric acid because we don't want our patient to get a GI bleed or an ulcer, but we're not wanting the glucose production to be increased, which can increase that risk of infection like we've talked about. So all these things we talked about, again, as risk of complications, we're on the lookout now postoperatively for the trends. We're looking at the vital signs, we're assessing the pulses and looking at the fluid and electrolyte balance, making sure they're not in an imbalance. You know, originally when patients come out of surgery, they typically will have less output than input because in the OR we're pumping them full of fluids. But in the postoperative phase, they should not have 3,000 milliliters in and only 30 milliliters out. If they do, there's an issue, right? So any of our preventative measures, the interventions, anything we talked about earlier, and these on this slide, these are all based on common complications that can occur postoperatively that we need to be able to manage and be on the lookout for. I'm pretty sure Professor Ray discussed this when she talked to you about tissue integrity, but the wound evisceration is a medical emergency. The very first thing that you do when you find this is you call for help. You call the surgeon, you call the rapid response, you get somebody in there to help you, you stay with the patient. You'll be covering the area with a sterile dressing, a non-adherent sterile dressing that has sterile saline. Soak the dressing with some sterile saline because you're actually covering up the parts of the organs that have come out of the body. So stay with the patient, assess them for shock, vital signs, and when the surgeon gets there, document your findings. More than likely, the patient will be getting prepped and ready for surgery. I'm not going to go into too much more detail than that, but I believe you've learned this with Professor Ray already as a complication, potential complication. So in regards with pain and comfort postoperatively, there are both pharmacological interventions and non-pharmacological interventions. For the pharmacological interventions, you're looking at both narcotics and anti-inflammatory medications. There are different routes that you can administer these medications. Make sure that you are staying on top of not only your patient's pain level and what they tell you it is, but
when you're giving them medication, you know when that medication is going to kick in, right? So you're reassessing them at the appropriate time, making sure that the medication is effective, and watching them, especially if you're giving medication in the intravenous route, make sure you're assessing them for respiratory depression. We've talked in the past that opioids can cause this respiratory depression, and the reversing agent is Narcan. You need to be aware of that. And a big thing with pain medications post-operatively is you need to stay ahead of the pain. Make sure you pre-medicate your patients so that they can do the activities you're wanting them to do, walk in the hall, participate in things. Non-pharmacological treatments or interventions, you really want to make sure that the patient is positioned appropriately, so they have the pillows cushioning where they don't have pressure on the incision. You want to make sure that you allow adequate rest. If they don't have adequate rest, that can increase their inability to tolerate that pain. A lot of times, especially in pediatrics, we'll do diversionary tactics. I can't tell you how many times I took a pediatric patient to the playroom, got him up and walking because he wanted to go, do an activity in the playroom. Now, adults, have to figure out how to distract them, but there are many things that you can assist them with: music therapy, breathing exercises, meditation. These are all good non-pharmacological interventions that you want to be encouraging your patient with. So once your patient has been discharged from, or is about to be discharged from your post-surgical floor, you want to make sure that you have provided good home care education, which includes things such as proper hand washing, hand hygiene to prevent infection of any wound, any type of care of their incision at home, signs and symptoms of infection. If they have drains or catheters, you want to make sure that they know how to care for those. Proper nutrition therapy, that they get adequate protein to promote wound healing. They eliminate foods high in sugar to hopefully prevent infection and promote wound healing. Pain management, drug therapy, if they're going home on pain management, again, they are educated on taking their pain pills in appropriate time frames so that they will do things. They will get up, they will move around. You want to make sure that they stay ahead of that pain even at home, and progress in their activities as their surgeon has prescribed. Okay, and to wrap up this lecture, let's look at those NCLEX key points in the postoperative phase. So in the safe and effective care, you want to make sure that you are using aseptic technique during all dressing changes. If a patient specifically has surgery on the face, neck, mouth, that oral airway, you want to make sure that there's suction equipment, oxygen nearby. All of those apparatuses are kept close in the event of an emergency. With health promotion and maintenance, reinforced to the patient after surgery about preventing those complications, right? I can't say it enough. You want to make sure that you're educating them on the coughing, deep breathing, splinting their area where the wound is, making sure they're hydrated so they don't have dehydration. They're using their incentive spirometer, the importance of early ambulation, not only to prevent the pneumonia and atelectasis, but also to promote the GI motility that we need improved on after anesthesia. If they are given activity restrictions prescribed by the surgeon, make sure that they are adhering to those. If their surgeon has told them not to take showers to keep the incision dry, make sure they're aware of that, and make sure they know the why, right? Make sure that they know the importance of why we're telling them and educating them on these things so that they will comply when they do in that postoperative phase and when they do go home.
Psychosocial integrity, make sure that you are explaining all procedures to not only the patients but the families. You're allowing both to express concerns. Make sure that they realize that pain medications, even the opioids, are not going to turn them into drug addicts, that they need the medication so that they can heal. We talked about the evisceration, wound evisceration being a medical emergency. Make sure that you call for help and you keep that wound covered up with non-adherent moist dressing. Make sure that patients are aware of alternative therapies, the relaxation, listening to music, guided imagery, distraction, breathing. And then lastly, on the physiologic integrity, make sure that you're beginning every assessment with that airway, breathing, circulation, disability, meaning that mentation, right? So just to wrap it all up, when the when you send patients home and you have given them discharge instructions, make sure it is clearly spelled out what they need to look for in complications, right? So what clinical manifestations of complications and when to seek medical care and who they seek it for. So if you have drainage that increases to, 30 mLs, or the drainage is increasing and not decreasing, you need to call the surgeon, and here's the phone number. You have a fever of 102, you go to the ER. So specific directions and numbers that they can have so that they can properly heal at home in their home care. So let me know what questions you have, and take good care.